Hi everyone, it's Joe Miller. This is a lecture in preparation for rounds this coming Wednesday, April 4th, 2018. I distributed an article by email, and this is the corresponding lecture to go along with that article. I'd like you to listen through this lecture, but at the very end, there's the context for preparing some patients for presentation at rounds, because we're all bringing our own patient for this particular rounds. So the title of this talk is Ethics of Providing Less Expensive but Less Effective Treatment. And of the core competencies, I think that the key ones to talk about here are, if we're talking about treatments, you have to have some medical knowledge to know whether the differences in treatment effectiveness are real. You have to have patient care in this story to have access to the decision-making process. Professionalism, it's really a question of your reputation in many respects. If you're providing a treatment that others view as inferior, it may affect your reputation in some way. Interpersonal and communication skills, you have to be confident enough to be willing to discuss the limitations of the healthcare system and the finances of a patient with them. For instances, when they don't actually have enough money or they don't have enough insurance to do what the conventional treatment recommendation would be. Practice-based learning and improvement, you have to address this in the context of whether or not changes in therapy provide real differences and what those real differences might mean to the patient. Finally, system-based practice. You'll see as we go through this lecture that there are two aspects to this decision process. The first is, does a patient have access to a provider? And the second is, does the provider have access to care? Because policies contribute to what the decisions and options are to you as a provider. As far as financial disclosures, what got me thinking about this topic was some work that I did in May of this past year of 2017 through the Fulbright Foundation, where I was a specialist and had an opportunity to go to Aravind Eye Hospital to consult with them on both education of technicians who work for them and also to provide recommendations for management post-operatively of refractive care for patients who have gone through cataract surgery. So again, the assignment here was to read the viewpoint in Lancet, published in 2016. It was titled, The Ethics of Expanding Access to Cheaper, Less Effective Treatments. The article was written by Prasad and Emmanuel. And the fundamental question that they're asking is it ethically preferable to provide a larger number of people with cheaper treatments that may be more toxic or less effective? Or is it fundamentally better to restrict treatments to a smaller group of people and provide them with a more expensive but more effective or less toxic alternative? And so it's really a population health question that they're addressing. When you're in a country that has limited resources, and I think the reality is all countries have limited resources, how do you change policy or affect policy to allocate those resources? And what controls the choice as a result of those policies? So it's not a question of one versus many. This is not a question of whether one person is going to get all the resources that might have been spread across others. It's a question of how resources may be made available and what choices or options are given to patients regardless of their resources. Because you'll see that it's a different question when you're dealing with a single person in front of you. If you have a patient that comes in and they have glaucoma, but they don't have insurance, this is an example of how this dilemma would play out for you as an individual. You have to make a choice for a treatment recommendation. You have to take into account how bad their disease is and whether it would be appropriate to offer a less expensive treatment, for example, timolol, to a more expensive therapy with knowledge of that individual patient, what their risk profile is, and what the consequences might be if they received an alternative therapy that is less expensive. So in this instance, when you're dealing as a physician with a single patient, the usual physician-driven decision-making processes and also procedures that guide us in research come into play. The decisions that you make are guided by knowledge of patient autonomy, beneficence, and non-maleficence. I know most of you have taken the city courses and these terms are described, but it's worthwhile reviewing them. First, autonomy. Autonomy is simply not allowing a patient to make their own decision, but rather to provide a patient with the knowledge and information and context so they can make an informed decision on their own. It's not simply saying you decide, it's you providing them with enough information that they can decide intentionally with their own best interest at heart. Now, beneficence is a guiding principle in providing both research situations as well as provision of care that says that we as providers have to have the welfare of the patient at heart, that the overall benefit that is received by the patient should be a guiding principle. And at odds with this is also the concept that sometimes we know that regardless of what we do, there will be some harm to the therapy, that we want to try and minimize the amount of harm that is inflicted or to provide the least amount of harm, but we recognize the fact that harm will happen, that there are often side effects. Sometimes these side effects are short-term, sometimes these are long-term, and you have to guide in your own mind a judgment that recognizes the two options may have different risk profiles and different side effect profiles. You have to inform the patient, and often you have to help make them make their decision. So when we're talking about individuals, we have a pretty good idea what to do. But when we're talking about managing the entire population, then we come into a different concept, and that's utilitarianism. And the first concept is that we want to make sure that we're treating people ethically. And so there's a principle of equality that emphasizes that for similar people, you provide similar case treatments. And what this is an argument that says you have a standard of care that's equal in low-income countries to that of higher-income countries. And this equality principle says that you as a provider provide the same highest level of care in all instances. And the second principle is that of justice. Justice says that when patients are getting treatment, presumably they're going to be better off as a result of that treatment. But if they receive no treatment, it's likely that they'll be worse off. And so there's an argument that says people who receive treatment, regardless of whether the treatment is the best or just better than no treatment, are better off and receive a chance for justice overall by having access to treatment, even if it is somewhat inferior. So what the authors concluded on the basis of utilitarianism is that it's ethical in the provision of care at the policy level to provide less effective or more toxic treatments on the basis of utility and equality that provide care for those who are worst off, and that expansion of treatments that are effective, even if they're not the most effective, should be the standard in global health. So with this in mind, after reading through the article, I would ask you to come up with a patient scenario, to please think back on a time when you encountered a patient that was not well insured and you were already in a care situation with them. So they were your patient, and you felt a responsibility to come up with a care plan for them, and you learned that they had limited resources. So that's the patient scenario. Think about it from the context of you as a provider. what were the decision points that guided you in making your decision? And with respect to autonomy, beneficence, and non-maleficence, what were your guiding principles and what recommendation you made? But then I'd ask you to go one step further and think of yourself 10 years, 10 months, or 10 days down the road when you are not just taking care of this one patient, but you're leading a team and trying to establish policy that guides what options are available for treatment in your system. Now, this is asking you to think about what would you do if there were limitations presented by existing policy. How would you change those policies? And what might you have to do in order to make more options available for the patient that you're describing in this situation? So, in summary, I'd like to thank you for taking the time to view this video and to read the article in preparation. And if you're interested in further work, this is an example of what we're hoping will be more of the flipped classroom concept, where lectures are given in advance and you come to the lecture prepared. Thank you very much.